Thank you for coming. My name is Jim Clifton, and I'm Chairman and CEO of the Gallup organization. And I'm not an expert on this subject, so I'm going to be your MC today. I just wanted to make a couple remarks as an American and as a businessman. We're going to be looking at this subject today, a lot of the attributes of our citizenship and whether or not they have insurance and how they're feeling. And, you know, we've put together just a massive poll. So we're interviewing 365,000 households a night, 1,000 a night. And along with Healthways, we figured out, what do you think, 50 or 60 questions that if we ask you all the way from depression to what you ate to how much you weigh, and we pretty much do a physical of America's health every single day. But actually roll 3 to 5 days together. A lot of the concern has been, we'll report this today, about what percent of people have insurance. And what a wonderful, caring thing for a great democracy like ours to care about. I just wanted to mention something else. One of the reasons I think this is super important is because healthcare ties to many more things than just people that are uninsured. I just want to open the awareness to that today. And we were talking a little bit about, you know, jobs, full-time jobs, as a percent of the population are the lowest they've ever been since the federal government started measuring them. So you can do whatever you want with unemployment. You can say it's the best it's ever been or whatever. You know, it's getting real messy now. But the number of full-time jobs to the population is 42%, as reported by the Department of Labor, and it's the lowest it's ever been. What that gets tied to is that companies aren't employing. There's about 6 million businesses in the United States. 4 million of them are mom and pop shops that average about 1.4. It means that there's only 2 million businesses that are actually the ecosystem that produces that number of 42%. And we ask them why they're not growing. So we do massive, intense quarterly. We say, how come you're not sticking your neck out and growing? What most people thought is they're going to say they can't get money. That's not what they say. They say regulations. Over and over and over again, they say regulations. We say, really, which ones? They say health care. That's first. We say, well, what is it about health care? And they go, we don't know. We just know it's bad. We can't afford it. So you see what it does? It causes them not to hire people. And then when you don't hire people, you can't get more customers, and everything goes wrong. Healthcare affects a lot more than just the 30 to 40, depending upon how you count it, million people that don't have health. It affects the whole country. I want to just give you one more miserable number, then hopefully somebody will pick this up a little bit. But something's very wrong with the spirit of free enterprise. I just want you to consider this as you watch these numbers. To feed that little rainforest or that ecosystem of 2 million businesses that create the tax system and the $16 to $17 trillion of GDP and all that. 500,000 businesses start a year and 400,000 close, which gives you a net of 100,000. That works. That's what it's been doing for about 15 years. If you said, where do we go to get jobs to keep this whole thing pumping along so we got enough money to pay for $2.8 trillion of health care, that's where the money comes from. It's okay. It's not great, but it's been pumping along because we have a net of 100,000 new startup businesses with employees in them. You got to have that or the healthcare system never works. See how everything's tied to everything? 4 years ago, that thing went upside down. It's a number nobody ever talks about. Now we have 400,000 businesses start. I see a few heads nodding. A few of you do know it. Nobody talks about it because it's such an awful metric. With 500,000 closing. So now we're running along at a net 100 upside down, but it's actually 200,000 off. And so you have an environment where people that are going to start a business say it's not a good time to start a business. When you ask them why it's not a good time to start a business, it comes back to health care. So there's you can choose which either one you want. The biggest problem is either that we've got 30 to 50 million people that don't have insurance, and they should because this is America, and it'd be horrible to not have insurance or health care. That's one thing. But the other thing that's closely tied to it, and it's clearly the chicken and the egg, is if we don't have a big booming system of free enterprise, we can't afford $2.8 trillion. It's been growing at an average of about 6.2%. I know the last 18 months, for a lot of reasons, it went down, but it's been growing at that. Which means in 10 years, it's going to be about $4.8 to $5 trillion. For you nerds in the group like me, if you add the stubs over 10 years of the increase over the $2.8 trillion we already don't have, add the stubs and it's $10 trillion. The subprime meltdown was only $3 trillion. You see the problem? So it's like a tsunami that came in. The healthcare tsunami is 3 times bigger than the subprime that shook the whole world. So I'm just saying, as we look at the data today, we have some great presenters. Gallup's 2 top people on this subject, and one of the top execs over at ASPE. Consider the whole picture. Consider the individuals, but you better consider our whole economic situation, because nothing's bigger than healthcare. I think after the cuts in military, I think they're going to be cleared down to only $500 or $600 billion. You see the point? So healthcare is 5 times bigger than what most of the public think is our single biggest budget. What we're going to do, some of you are in our group, in the audience here, are clients, but Healthways and Gallup is making a commitment to tracking all this stuff nightly, and then we're going to make important reports, not just quarterly, but whenever we have them. I think we have 3 important ones today. Most all media in the United States and around the world is on our website every day, trolling for stories. We're going to try to report in a very neutral, nonpartisan way what we think the current condition is of healthcare. Not just ACA, but also, do you have healthcare yourself, and how satisfied are you with your current health and your current expenses? So with that, I want to introduce to you Gallup's chief scientist for well-being. So he's been at Gallup for about 20 years, and he spends his whole day just sorting through, I'm sure he does some other things too, most of his day, sorting through infinite combinations of data about what's on the mind of Americans. But also, as I was saying, have you been diagnosed with cancer, you've been diagnosed with depression, and you can mix it and match it by people that are unemployed, have insurance, and on and on and on and on. He's kind of unofficial. He's the unofficial pollster, Surgeon General, on what's right or wrong with America. And his name is Dan Witters, and I'm going to turn the program over to him. Just before I say, if you look at your program, we're going to have Mike Eaton. Mike Eaton woke up ill today, and so we're going to pass him, and we'll start with Dan. So please welcome our own research director, Dan Witters.
Thank you, Jim. Good morning, everyone. Thank you all for coming. It's very nice to have such a big crowd here. The important topic that we're addressing today has more directly to do with the first of the 2 things that Jim was talking about, and that's the access to insurance, the access to health care part. What I'm going to focus on are Gallup-Healthways Well-Being Index data. So I did want to invest a couple of minutes up front just to tell you about the data set so you have an idea of what I'm using for my sources and the strength and stability of the data that are embodied in these results. The Well-Being Index is something that Gallup and Healthways launched to a lot of fanfare back in January 2008. We are at 2 million and counting completed interviews with randomly selected American adults. That's 18 plus. We don't interview kids, but we do interview 18 plus. Over the course of those years, we go every night except for the major holidays. So this is prolonged exposure, right? And with that prolonged exposure, it affords us the opportunity to do really good trending and tracking of some important metrics, including health insurance. When it comes to that, we have different questions that we can leverage, and Frank has some really great stuff that he's going to share with you that we've also captured a little bit later on this morning. What I'm going to stick with, though, is just a single metric that's a part of the well-being index, and that's, do you have health insurance coverage? So it's really where the rubber hits the road as far as this particular metric is concerned. The data collection is all outbound phone with a live interviewer, and it's modified a little over the years. One example is that our percentage that sell has gone up, and now over a third of American adults are sell only. So you have to include a big chunk of sell in your sample frame, and we do. We do English and Spanish. So between that, we're at least 95% projectability to the broader U.S. population. Not everybody speaks English, Spanish. Not everybody has a phone. Deafness and hearing impairment, maybe 1.5% of us. But we're at least 95% plus. So we have very good projectable data. And then we weight it back to Census Bureau statistics. So the data, of course, are weighted to make it look like we're perfectly aligned with what the Census Bureau says it ought to be. So that's that part of it. The data collection is also vast. For the first 5 years, at 1,000 a night, we're going over 350,000 completed interviews per year. So it's a big data set, about 88,000 per quarter, about 45,000 per month. Right? Very small error ranges associated with those. Beginning in 2013, Gallup and Healthways expanded our well-being measurement, our charter internationally as a part of the Gallup World Poll, which was a big, exciting step for our well-being measurement. But as a part of that restructuring, the domestic polling got cut in half to 500 a night. So now we're down to only about 178,000 in 2013. 44,000 a quarter and about 15,000 a month. So I put that up there for you so you have a sense for the sample sizes that we're talking about, because most of what I'll show to come after is zeroing in on quarterly and monthly sample sizes. Okay. Let me start at the highest level, and that's trending uninsured going back to quarter 1, 2008, right up through March of 2015. Again, pretty big sample sizes, right? So if you start over here, I don't know if you can see my pointer. Back in 2008, we were kind of in the 14s range. With the Great Recession, we saw a little bit of a spike. So the labor market matters. Okay, as people lose jobs, you're going to have fewer people that are collecting insurance via their employer. But generally, it's continued to move up. Even as the labor market has healed, you've seen an upward slope that has occurred with the percent without insurance. Now, one thing that happened in this range here, 11 and 12, you see it kind of drifting down. That's the 18 to 25 rule at work. The 18 to 25-year-olds that can stay on their parents' plan. 18 to 25-year-olds are an important group because they have very high levels of uninsurance. Not as high as the 26 to 34-year-olds. Those guys are up to about 30%. Very high. But the 18 to 25-year-olds, mid to upper 20s. And during that stretch, they came down about 4 to 5 percentage points. And that's something that Gallup tracked and reported on at the time. So that decline was enough that it kind of dragged down the overall score by about a point. Okay. What has happened, though, here, as we kind of resumed our long-term trend up, is that the 18 to 25-year-olds kind of hit their bottom, and then they slowly have started coming back up again a little bit. Not up to the previous levels, but they've drifted up. In the meantime, the other age groups between 25 and 64 have climbed a couple of percentage points, and that overall thing has kind of gone up. So the long-term trend has continued on. It's culminated in quarter 3 of 2013. That was the highest quarterly measurement we ever had. Now, again, that's 45,000 randomly selected American adults, so it's not a small sample size. Okay, it also happens to be the 3 months immediately preceding the opening of the exchanges, which was October 1, 2013. So I put that in big bold as kind of our last big measurement right before kind of the core elements of the Affordable Care Act kind of started to come online. Since that time, we've seen a decline. We've seen a decline that is both statistically significant and meaningfully large. It's also now at a point where we are, I think, comfortable attributing the decline that we're seeing to the core elements of the Affordable Care Act, not necessarily only attributable to it, but I think it's fair to say that it's having a significant impact on the decline that you're seeing represented on that slide. So from this, we can make projections, and we'll do that. I'll start with a caveat, and that is that when you project about the number of people that have now gained insurance who didn't have insurance before, you see lots of different estimates coming from the politicians. You see real high numbers coming from Harry Reid and the Democrats. You'll see very low estimates coming from Speaker Boehner and the Republicans at times. But what we can do is just ask Americans, do you have health insurance coverage? And then we can track the change and we can come up with projections. Now, what you use as your starting point is going to affect that. Do I use all of 2013? Do I use a 2-year average? I'm just using those 3 months that came right before the exchanges opened. That was our last full quarter of measurement. Then on the back end, I'm going to use March, which is our last full month of measurement. It's a moving target, but we'll use that 15%. From that, then, this is the numbers that we come up with. The top is our best estimate of the total number of uninsured, the net reduction of uninsured since quarter 3 of 13 by March of 2014, 7.26 million. That's the net reduction people without health insurance. The high-end estimate's about 9.9 million. The low-end estimate's about 4.5 million. So way out on the end of either tail. Those would be the high and the lows. But our best estimate, the one that would be most reproduced if we did lots of different samples side by side, would be about 7.2 million. So the number of people without health insurance has declined, and it's declined in the millions since quarter 3, 2013. Okay, let me move into race and ethnicity. I want to dedicate just a little bit of time to this. Frank has some very interesting data on age and health of the newly insured. I did want to talk a little bit about this, though, because this is something that also gets some play in the media, gets some play among the pundits, and I wanted to address it, particularly with the Hispanic population, but then we'll talk about all the rest of them. The Hispanics carry a certain notoriety when it comes to this issue, because people of Hispanic origin or descent have high levels of uninsurance rates, right? They just do. They have steadily over the years. If we go back again, starting at Q3 of 13, 41.4% of Hispanics did not have health insurance in America, compared to 20%, 14%, and about 12.5% of blacks, Asians, and whites. The whites are the green, the Asians are the purple, the blacks are the blue line. So it's much higher. The question is not just what's the rate, but how has the rate changed? Because the other part of the notoriety around Hispanic Americans is this notion, some of it anecdotal, some of it based on available data that's out there, that the Hispanics have not been getting on board with the core mechanisms of the Affordable Care Act and ergo are not seeing their insurance rates being reduced. That's not true, but based on how you look at it, there is some support for that notion. The first point is just looking at the percentage point reduction, right? That's just the first number, subtracting the second number, and you come up with that. Right? So the Hispanics have come down 4.4 percentage points. That's more than any of these other groups. The 3 major racial groups have all come down around 2 to 3 points. When we look at, though, as a percent reduction, that's just that number divided by that number. Right? Then it is, in fact, a little bit lower. So proportionate to the starting point, the Hispanics are not declining at the same rate as the other 3 groups. But there's no doubt that the percent uninsured among the Hispanics is declining, and in absolute terms, as a percentage point reduction, is actually a little bit more than the other groups. All right. Let me move into the states. Every year, as a part of the Gallup-Healthways Well-Being Index, we put out state measurement and look at the uninsured rates. Massachusetts, every single year, leads the nation. That's the Romney Care model, right? It's about 5% of Massachusetts adults do not have health insurance. Very consistent number consistently the best in the nation. On the other end of the spectrum, okay, and so I'm just showing you the 13 states that are under 13% uninsured. Over on the right-hand side are the 14 states that are 20% or higher. Okay, so for them, this is no joke. At least 1 out of 5 adults do not have health insurance in those states. There's a lot of them that are kind of the usual suspects. A lot of the border states you'll see on there. You got Nevada, New Mexico, Arizona, Texas, of course. Texas in particular, every single year on the opposite end of Massachusetts. Every single year, Texas has the highest percentage of uninsured in America. So that part of it, those are two of the most easily predictable in advance statistics that we have through our ongoing measurement. Texas highest, Massachusetts lowest. Now, in the meantime, we can look at how states are implementing these core mechanisms of the Affordable Care Act. The two real big ones are setting up a locally managed and promoted exchange and Medicaid expansion. Okay. When we do that for this analysis, what I have done is I've just looked at the states that have done both. Not one or the other, but both. And what we have are 21 states plus D.C. We'll toss D.C., of course, in there, and that's a part of this team, that have expanded Medicaid and have set up a state-based exchange or a state-based partnership. Some of them do those kind of hybrid state-federal partnerships. I think it's appropriate to include those on this group, so that's here too. You've got 4 states that have expanded Medicaid but have not set up their own exchanges, right? North Dakota, New Jersey, Ohio, Arizona. They're on the other team. Other states, New Hampshire is a good example, recently voted to expand Medicaid. They've set up their own state exchange. But because their Medicaid expansion doesn't kick in until July 1, they're on the other team. Okay, so you guys get the idea of the analysis rules behind this. We have 2 sets of states. The first thing we did, and this is looking at all of 2013, not quarter 3, but just all of 2013, for these states. The first thing we did is just kind of compare the two. The states that have implemented both of these core mechanisms, we note, have lower levels of uninsured to begin with. The states that have not implemented them or have implemented only one or the other have higher levels to begin with. Okay, so they're not starting at the same point. But where the rubber really hits the road and where the plot thickens is when we look at the change over time. So now we're moving forward and looking at quarter 1 2014 numbers. I'm not using March, I'm using quarter 1 2014 because I wanted to keep my sample sizes larger. But when we look at that, this is what happens. Quarter 1 14, the groups that have implemented those core mechanisms, those states plus D.C., have dropped by 2.5 percentage points. The ones that have not have dropped by less than a point. So the ones that have implemented both core mechanisms are reducing at about a 3-to-1 rate compared to those that have not. And that gap between them now is widened. It's gone from about a 2.5-point gap now to a 4.3-point gap. So you can see the effects, regardless of your perspective on the wisdom or the efficacy of the Affordable Care Act, there are certain core mechanisms that are intended by design to lower the percent uninsured. And you can see the effects of those states that are going after that compared to those that are not. Compare them side by side. Okay. You're not going crazy. You have seen this slide before, but I'm going to return to this one because I want to talk a little bit about April. We're halfway through April, after all. And so we don't have official results, but we do have preliminary results that Frank and I felt comfortable sharing. So through about 7,000 respondents through the first part of the month, the question is what's happening with that trend? Is it leveling off, or do we see a continuation of the trend that has started since the end of 2013? What we have so far in April is 12.9%. Now a precipitous drop compared to previous levels. Very clear, unambiguous decline in the percent uninsured at this point. The other point that I want to make is that 12.9 right there, if that holds, will be easily the lowest level of percent uninsured since Gallup and Healthways began this monthly tracking 76 months ago, back in January 2008. The previous low was in September of 08. That was 13.8% that month. So the 12.9 will easily surpass that low point across the 6+ years of measurement. Okay, so that's what we've got right now. We won't come out with our official April estimates, of course, until the first week of May. As we do every month, we put out our updated numbers in the first 4 days or so. That shows the quarter-to-date numbers as well as the most recent month's figures. And so that'll be coming out. But right now, so far in April, down to about 13% uninsured.
Say, Dan, what, if you just had to guess, what do you think May will? Do you go to single digits in May if you had to bet your car?
No. But so the exchanges are wrapping up now. We still have, and of course and there's lots of things that feed into this. And so you have people that, one of the things is, are you actually going to pay for your premium? And for those that don't, we can expect to see kind of a buoyancy back in that number that might start lifting it back up over time. I don't think it's a bottom. I think we can expect that to go down a little bit further, but I don't think we're going to reach single digits. If you look at the CBO estimates for what they think the Affordable Care Act can accomplish eventually, years down the road, it would be enough, we think, to get our estimates into the high single digits. I don't think we would ever expect our estimates to get down to, say, the Massachusetts level of 5%. I think we could expect to see our estimates dropping in the 8 to 10% range. Eventually. Okay. So that's what I've got, and I'm going to turn it back to you. Thanks very much, everybody.
Thank you, Dan. We're very lucky to have with today the Associate Deputy Assistant Secretary for Health Policy in the Office of Health Policy. We have the Assistant Secretary for Planning and Evaluation, I think it's called ASPE, from the U.S. Department of Health and Human Services, from HHS. So with that, please welcome Nancy DeLue. Nancy?
Okay, so my first test is making sure you can all hear me. So I'm very happy to be here this morning. Thank you for inviting me. Now that the initial enrollment period has concluded for the health insurance marketplaces, as you noted, Medicaid enrollment is going to continue. The open enrollment period, October 1st through March 31st, applies to the health insurance marketplaces. Medicaid enrollment continues. It doesn't have that same 6-month bounds, so we expect people to continue to be enrolling in Medicaid coverage over the rest of this year. One of the key questions is the extent to which the uninsured have signed up for Medicaid, for marketplace coverage. How's that? Okay. Or whether they've got insurance through their employer. You know, one of the things I would note in Massachusetts, which you highlighted, they're having the lowest rate of uninsurance in the country. One of the things we saw in Massachusetts after the expansion there was that more people got employer-sponsored insurance in Massachusetts. So we may be seeing that here as well. So in ASPE, we're looking at many different sources of health insurance data to be able to answer some of the key questions. And we're looking to the Gallup survey as one of those key data sources. We're also looking at surveys conducted by a number of other entities. They've been featured in the news reports of late as well. The Urban Institute has a survey, RAND has a survey, McKinsey has a survey. So there's a number of important data sources that we're looking at to track the changes in health insurance status in real time. We purchased the Gallup Daily Feed. That provides us with real-time information on changes in health insurance coverage. We've found our analysis of the Gallup data to be very helpful in the initial months of 2014 as we've tracked changes in health insurance coverage. The data that we get from Gallup, we all know that the national surveys that the federal government conducts, both in the Census Bureau as well as in the Department of Health and Human Services, those major national federal surveys are not available yet. They won't be available for some months to come. So in the meantime, while we're waiting for those surveys to be available, we're looking at all the other surveys that other folks are putting out, and we find the information for our purposes to be very helpful. I want to just note what you talked about earlier in terms of age group, race and ethnicity. We're looking at a number of we want to track national changes in health insurance coverage as well as by other characteristics, age being one, race and ethnicity being another. We'll be looking over the next number of months to see what worked well in our outreach efforts for 2014 and what we can do to improve them for 2015. Open enrollment for the marketplaces, the next round for 2015 starts November 15th. So we're going to be looking over the next number of months, and we'll be using data from Gallup and other sources to see where we had higher rates of insurance pickup among some groups than others to help inform the efforts that we'll undertake for 2015. We've published a number of issue briefs that have drawn on analysis of the information that we've received from Gallup and other surveys, as well as our own administrative enrollment data. We have a research article that just came out yesterday where we benchmarked the Gallup data against the other major national surveys and found that for the country as a whole, Gallup tracks well with changes in health insurance coverage. So I think I'll conclude right now. I know you have other data and other information that you want to report to the group by saying that we've found the data that you all present to be very helpful to us as we track changes in health insurance coverage over this first open enrollment period. So thank you.
Thank you. So Frank's going to make a few comments, then Nancy and Frank and Dan will be on the panel, and so hopefully you'll have some hard questions for him. The Gallup poll, Dr. Gallup started the Gallup poll 80 years ago in Princeton, New Jersey, and for the last 20 years, our editor-in-chief has been Frank Newport. The Gallup poll gets quoted virtually every day all around the world on a myriad of wide variety of subjects. And this is the guy that's in charge of that. So please welcome the Gallup poll editor-in-chief, Frank Newport.
Thank you very much, Jim. Nancy, thank you very much for your comments. And Dan, thank you for your very sagacious analysis of our ongoing tracking data, which is very, very important. As Dan mentioned, one of the characteristics of our tracking data, both the Healthways data and also we have a separate track which we conduct where we have presidential job approval and economic measures and a number of important measures independent of Healthways. One of the important characteristics of those ongoing tracking methodologies is that it is a cross-sectional sample that is independently done every night. Now, for those of you who are methodologically inclined, that means it is not a panel study. In other words, we are not following the same people night after night. Instead, every night is a brand new sample that is selected and, of course, weighted in exactly the same way, which has a lot of positive virtues. One negative virtue is that we're not able to follow the same people and isolate people who may have changed over time. So when Dan presented his data and showed that there was a decline in the overall marginal rate of the uninsured in the country, we are not able to go back into those data and say, all right, who are these people who have declined? Because every sample is independent. If it had been a large-scale panel sample, we could go back and say, all right, let's isolate the people who, as Dan pointed out, in the third quarter or the fourth quarter of 2013 did not have insurance, but now who have told us that they have gotten insurance since, and then we could look at those characteristics. But we can't do that because every sample is independent, if that point makes sense. So we scratched our heads and spent some time experimenting, and fairly recently, actually March 4th to be specific, we made the decision that we would do a bootstrapping retroactive panel study where we would interview people in the current sense and ask them to recreate for us their past so that we could then isolate the people who have gained insurance and some other things that we want to look at. So let me just repeat that. What we're doing is bootstrapping a panel study by starting on March 4th. Every night we ask people who have health insurance, did you, well, first of all, as I'll show you in a moment, we say, is this a new policy for 2014? If they say yes, we then follow up and say, all right, please tell us, did you have insurance in 2013 or not? And finally, we ask these people who say they have a new policy for 2014, did you get this policy through an exchange? So by engaging in that process, we are able to isolate a group of people who retrospectively now tell us that they are the people who are newly insured for this year. There's some error in there, but there's going to be error in any measurement, of course, as people try to recreate where they come from. Therefore, I'm going to show you the results we have with the caveat that since we started March 4, I pushed this as far as I could. I went all the way through Monday night to make sure we had the maximum amount of data, but we still have a fairly small sample size because we're talking about small groups of people. So the data I'm going to show you are going to build. We're going to continue to ask the questions, but at this point, these are estimates, and I want you to make sure that you understand that we're basing this on a large sample of over 20,000 adults that we've interviewed since March 4th, but the people that we've isolated that we finally can drill down to and who tell us retrospectively they're newly insured is a fairly small group of people, significantly under 1,000. But those are the people we're going to look at initially. When I'm through with that, I'm going to point out briefly what we've been tracking in terms of the political implications of the Affordable Care Act, which I think is important. Because in a democracy, if we have the population negative or positive towards a major piece of legislation, it can affect where that legislation goes. And it also, we've shown in our data, can affect actual sign-up for new health insurance policies. I'll show you that in a moment. But Republicans who have highly negative attitudes to the Affordable Care Act based on their self-reports are also much less likely to, uninsured Republicans are much less likely to sign up for health insurance. So you can say, well, this is not a political issue at all. We're talking about, as Jim said in his introduction, getting people insurance, but politics enters into everything that we do in this country today, and we can show you that actually politics can have an impact on the number of people who sign up for insurance. Finally, I'm going to show you briefly some experimental design testing we did to try to estimate what the impact is going to be when the fines for not complying with the individual mandate go up, as they will legislatively, right? We have legislatively built into the ACA an increase in fines, although it's complex what they'll be. We have an increase in fines going forward, and we can show you some estimates of what the implications are going to be for that. So with that said, we can get forward. As I mentioned, we're talking about 20,804 national adults interviewed from March 4th through Monday night of this year. And again, I won't go through it again. I'm explaining what we did. But the first question we ask is this a new policy for 2014? So 11.8% of our adult population tells us that they got a new policy in 2014. However, and this is the important data here, we followed up and 7.5% of those say it was a policy that was not new. It was a replacement policy that we call it. In other words, these people say they already had a policy last year. They have a new policy this year. Maybe they changed jobs. And as I'll show you in a minute, some people who came through the exchanges, a significant number were also replacement policies as well. So that leaves a key figure of about 4% of Americans who are the newly insured. And that's a key figure that I'm going to come back to in a moment. Because that is our estimate of people who are newly insured in 2014. That is people who say they have insurance for the first time this year and did not have it last year in 2013. That's roughly in line with the data that Dan was showing, which comes at it in a totally different way. If you take an 18 percentage point high from last year and it's dropped by about 4 points, you'd be down to about 14%, roughly in the range where we're going now. We can't compare precisely because, of course, what we're not measuring is people who, in these figures, might have had insurance last year and don't now. In other words, people who dropped off for a net-net. So it's not precisely comparable. But the 4% of all adults who now newly insured, in a very rough sense, seem to comport with the other data that we have available at this point, with some caveats about how to look at it. We have, within that 4% group, and again, that's the real key group, we followed up, and we found about half, since it's a small sample, I would say roughly half, came through the exchanges, but that means about half of the newly insured did not come through the exchanges. So I'm going to show you in a moment the characteristics, and these are significantly different groups. People who came in through the exchanges based on our initial preliminary estimates look to be significantly different than people who've come into the insurance pool this year not through the exchanges, and I'll get into that in a moment. This is saying the same thing with a nice diagram. How's that, right? People who are numerically challenged. I'm setting you up for a fairly dense chart that I'm going to show you in a moment, so I wanted to give you a nice picture. Newly insured for this year, 4%, and it's, given the sample size, is roughly half and half is what I would say. Half of the newly insured seem to have come in through the exchanges and half came in elsewhere. Now, I can back this in a totally different way. Don't be confused by the fact that this is also 4%, but this is a totally different figure. 4% of Americans this year say that they got a health insurance policy through the exchanges, 4.2% to be precise, based on our estimates. However, as I mentioned a moment ago, about half of those Americans who use the exchanges to get a policy tell us that it was a replacement policy, that they did have insurance last year, which leaves about half who said they came in through the exchanges and got a policy for the first time. So it all matches up because that 2.1% add another 2% who didn't come in through the exchanges, and you're back up to the 4% of newly insured this year. So from a totally different perspective, for those involved with the exchanges and healthcare.gov, they were effective in bringing in people who were newly insured, as was their primary intention, but they also served as a mechanism for individuals to get a new policy, but people who already had a policy from last year. Now, question is, who are the newly insured? And again, these are estimates, but I think they give us some pretty good initial preliminary indications of what we're looking at with the newly insured this year. And here's the challenging chart. What I've isolated for you here down the right-hand side, the left-hand side, are all of the newly insured. That's the 4% in 2014. Then I've broken it out into these two small groups, those who came through the exchanges and those who didn't. And then I estimated for these exact same periods of time, March 4th through April 14th, the characteristics of the national population on these same parameters. So question number one is age, and you can look across, and there's face validity of the data because of all of the newly insured who told us they have policies this year, only 2% say they're 65 and over, most of whom are covered, as you know, by Medicare. So it does look to us like almost all of those individuals that we've isolated as newly insured this year are in the 18 to 64 frame, which we would expect overall. That was the target overall for the insured, given that we already have in place a federal program which insures those who are 65 and over for the most part. You can reach your own conclusions looking across. You see the population, since we have 19% during this time period were 65 plus in our overall weighted sample, and of course we're down to 2. So naturally, the percentages in the other three age categories of the newly insured in the left column are all going to be higher, or should be higher, because you're cramming all those, the distribution has to cram those older people into the younger group. They have to expand. But with that said, it does look like, and I isolated in red, that there is a slight youth skew, that 30% of the newly insured are in that 18 to 29 category as opposed to 21% of the population. Another way of saying it is the difference between those three under 65 age groups and the population is larger, the gap, so to speak, the 21 to 30 is larger for the 18 to 29s than for the other two age groups. So it does suggest overall that there was a modest skew to younger individuals in the newly insured population, although not dramatic. In other words, notice a very significant percent of the newly insured were 30 to 49 and 50 to 64. So by no means does our data suggest that the newly insured are all isolated in the young 18 to 29 age group. It's fairly evenly distributed across 18 to 64 with a slight skew towards those who are younger. Now, you can look at small sample sizes, but you look in those middle two categories, and you can see that the exchanges actually skewed older than people who came outside of the exchanges, which is interesting because one of the marketing targets for the healthcare exchanges was young people. Clearly, if you saw the advertisements and all that. But actually what happened is the newly insured who are the youngest are those who came in outside of the exchanges. And I'll show you in a moment, it looks like from our estimates that a lot of that is because those who came in throughout the exchanges are employed. They're significantly more likely to be employed than those who came in through the exchanges. So the exchanges seem to function more for unemployed individuals who were uninsured and brought them in, and they skewed older. Those who found insurance for the first time outside of the exchanges came in outside of the exchange. Just hold on a moment and I'll come back to your questions. Bottom line here is it does look like the exchanges skewed, clearly they skewed under 65 as we would expect, but within the 18 to 64 group they skewed slightly younger as we would expect. Not the exchanges, the newly insured, but the exchanges themselves actually skewed somewhat older within that population. Now, health. This is a telephone survey, so we don't have the capacity, of course, to take the waist circumference, the BMI, the blood pressure, and a detailed medical history that would be nice to be able to know what people's health really is. So what we're relying on here is self-reported health. And these are the 5 categories that we've used in our Healthways survey, and we've incorporated these into this analysis here. Again, this is self-reported health. does have validity. We've cross-validated this measure, and it does seem to work within our own survey context as being a pretty good predictor of what people tell us in many other instances later in the survey about having been diagnosed with this problem or that problem, or their BMI, or a variety of other indicators. So we believe self-reported health is a fairly valid indicator, with, of course, as is true for any self-report measure, some error variance around the edges. Well, you see the overall population parameters, and then you see, if you look on the left-hand side, the health of the individuals. And given the smaller sample sizes, my conclusion, comparing the left column to the right column, is that the newly insured in 2014 basically mirror the health of the overall population. There's some minor differences. See the 16 versus 21 in the excellent category. But given the margin of error and some other things, I think the broader conclusion that I just mentioned is more warranted. That is, that the newly insured who come into the system this year basically are neither sicker nor more healthy than, based on self-reports, than the overall population. Now, maybe in the Q&A section we can interpret that. As is true with many other things in life, is that a half-empty or a half-full glass, and partly that depends on one's interpretation. Clearly, the uninsured probably had worse health to begin with, which is an indicator. On the other hand, clearly the proponents of the ACA were hoping that they would get a lot of people with good health, mainly so they wouldn't draw on the system, right? Young people are valuable because they're healthy, and it's just like our car insurance, right? They love you to State Farm to be a car insurer as long as you don't ever file a claim, right? That's who they want once you file a claim. Or like my wife in our health club membership. She goes rarely, so they love her, right? She pays the money but doesn't go. And it's the same idea. You know, the ACA needs people who pay regularly and don't draw down on the system. You'll notice, however, that those who came in through the exchanges do look like they have at least modestly worse health than those who came in elsewhere. And, of course, that fits in with the age distribution that I showed you a moment ago. We can't avoid politics. The skew towards Democrats, as you see in the population during this time period, there was a 4-point skew, Democrat over Republican. You see it's significantly more Democratic. That comes from two places. One is the young and lower income individuals tend to be more Democratic in political orientation, so it's an underlying variable. And second is what I mentioned a moment ago, that Democrats are more positive towards the Affordable Care Act and the exchanges in general, and therefore behaviorally, it seems to us, are more likely to want to sign up. An uninsured Republican, to repeat, is less likely to sign up based on all of our data from what we've looked at because of their attitudinal objections to the Affordable Care Act. So like it or not, politics intrudes its head into what we're talking about here today, as I mentioned. Finally, income. There's no question that those who are newly insured skew lower income, 38% overall in that very low income category compared to 23% in the overall population. And again, those who came in through the exchanges, slightly lower income than those who didn't. My bottom line comes with the top two categories here, which is that the newly insured who've come into the system, our attempt to isolate those people that Dan's chart showed disappeared from the ranks of the uninsured, do seem to be perhaps modestly or slightly younger than we might anticipate based on the population comparison. Clearly, they have lower incomes. And I would say they are neither fish nor fowl when it comes to health. They generally look like they have a roughly even health distribution compared to our population parameter. A couple of additional points. I isolated only 18 to 64s to get that 2% out of there, and I also took out the 19%. And basically this shows, again, there's some differences. And if we were dealing with 100,000 people, I would make a big deal about the differences. But given the small sample sizes involved, again, my comparison, even among 18 to 64s, their health distribution, 1864s and the newly insured, roughly mirror the health distribution of the 1864 population during this same time period. Perhaps a little less likely to be in the excellent category, but more likely to be in the good. And clearly, I don't see a statistical difference in the bottom categories. I alluded to this earlier, but I wanted to show you our employment statistics. These are only the individuals who came through the exchanges and didn't, and it clearly shows that the newly insured who didn't use the exchanges were significantly more likely to be employed full-time. And that's why they didn't use the exchanges. So one positive thing that has happened is, apparently, the publicity and the pressure that came with the Affordable Care Act has generated more individuals who are employed to get insurance than was the case previously. Whereas the exchanges seem to function more as a mechanism for individuals that did not have an employee pathway to insurance to use to get insurance, and in some ways that's what they were intended to do. Healthcare.gov and the exchanges were set up to enable people to get insurance who may not have a way of doing it independently. So these data show that to some degree that system certainly worked. A couple of other points I will make, and then we had a question here, and we'll certainly, I think in our question and answer period, take that. Yeah, then we'll have the questions when we go up here. Hold that question, I'm sure it was a sharp one. Let me just go through a couple of other things here. These data are widely known because, Nancy, you mentioned that a number of organizations are tracking the uninsured. Well, even more organizations are tracking political perceptions of the Affordable Care Act. So there's a lot of data out there about the Affordable Care Act. And there are some differences by survey. For example, the ABC Washington Post had a poll where they don't mention Obama in the question wording and had some other things and showed, oh, geez, there was actually a slightly more positive than negative finding in the most recent poll. But the preponderance of all polling that I've examined shows a continuing negative rather than positive view of the Affordable Care Act by the overall 18-plus population. And that's our trend, first of all, on familiarity, just to show you. Americans claim to be familiar with the Act, 72%, but that really hadn't changed over time, which has some interest, I think, in and of itself. But this is the big chart. There was a flex point that came initially, that was right after Obama's election, December 12th, positive attitudes towards the Affordable Care Act, became more negative, started to become more positive again, and then after the publicity which surrounded the less than auspicious debut of the exchanges in healthcare.gov last October, which was partly obscured by the government shutdown but became very evident in the press, partially the publicity that accrued to the president saying that perhaps you can't keep your health care plan if you want to, and of course that was made hay of by certain people in the media. All that seemed to have been a flex point where the negatives went back up again, where they looked like they might have been closing. And since that point, they've stayed fairly constant. We had expectation that after the positive publicity of the 7 to 9 million, whatever the figures are, that have signed up in the exchanges, the victory for Obamacare that's certainly been part of the publicity since the exchange closed officially at the end of March and now unofficially with the extension that was granted just yesterday. We thought maybe we would see another flex point where attitudes would become more positive. They may. Sometimes there's a lag effect, and as Jim said, I've been doing this for a number of years, and sometimes it takes a while for this to percolate through to the population. A couple of surveys have said they're seeing the beginnings of a more positive trend, and you know, you can stretch our data and say, well, it's up a little, but basically that's not a lot of change. So these last data came in as of a week ago, after the April 1st end of the official enrollment period, and we certainly have not seen much change in these negative attitudes towards the Affordable Care Act at that point. Stay tuned. We'll continue to monitor this on a monthly basis, and we may in fact see some change. Now again, you say, why do we care? Well, I told you why we care, right? That the attitudes toward the Affordable Care Act guides behavior, and behavior is the purpose of the Affordable Care Act, so its image is not trivial. Both for the opponents and opponents, the image of the Affordable Care Act is a very significant factor because it actually can relate to behavior of the uninsured in the population. Highly political at this point. This is some statistical analysis that Andrew Dugan, a colleague of mine, did recently. The Republicans, basically what it shows, when you put it in a model, it's politics that determines what you think about the Affordable Care Act. Not your income, not your insurance status, not anything we can find, race somewhat in there. But basically your politics are what determine your attitudes to the Affordable Care Act. And again, that matters because Republicans simply are saying, I'm not going to sign up even if I don't have health insurance coverage. Of all of those who approve of the Act, 78% are Democrat in our last reading, or lean Democratic. All of those who disapprove, it's almost as many Republicans. So one's attitudes toward the Care Act, not a great shock. After all, it has a Democratic president's name in the sobriquet, the nickname that is used, Obamacare. But nevertheless, that demonstrates for this aggregated sample how political the act is, and that has a powerful impact on Republicans' likelihood to sign up. We did see this change, and this is one I wanted to highlight. When we track a lot of measures, this is asking you about the effect of the Affordable Care Act on your family in the long run. And notice what happened most recently. This was the most dramatic change we saw. We saw a flip where more Americans are now saying it'll make no difference rather than it'll make my situation worse. So that's a modest victory for proponents of the Affordable Care Act, because we have fewer Americans now saying it's going to make it worse and more say that it'll make no difference. And mostly that was driven by attitudes that changed among Republicans. Notice the difference there. Republicans went for no difference from 23 to 43 points. Look from the Democrats up and look at the independents up, not much change at all. So the good news is Republicans, who are the opponents of the Affordable Care Act over here, have said, all right, I'm going to quit telling a pollster that this is going to make my situation worse, but I'll just say now it's going to make no difference. So that's a modest victory for proponents. They would hope to put them in the better category ultimately, but at least they've moved them in that direction, and that's why we saw the change. Final point, one slide. The fines for the Affordable Care Act are going up. Nancy, you might want to explain how they're going up, because I don't understand. It's like the minimum of your income or a set dollar figure, or maybe there's some other caveats, right? It's quite complicated what you have to pay as a fine if you make the decision not to comply with the individual mandate. But we tested 3 fine levels kind of arbitrarily. None of these match exactly what's going to happen. These were a split sample experimental design, so over a period of time we randomly assigned a third of the sample to a $95, $500, and $1,000 fine each, and said for each, if you knew that the fine, these are only the uninsured we're interviewing here, if you knew that the fine for not complying was X, 95, 500, would you sign up or would you continue to be uninsured? And what we have found is that the impact comes from $500. There's very little incremental impact in going to $1,000 over $500. But when you move from 95, which is the current, except if you have a low overall income fine, to a 500, you get about a 13 percentage point increment of the percent who comply. So in terms of, Jim asked Dan the question, where's the uninsured rate going to go? It does look like when higher fines kick in and are made known in the years to come, that may in fact push down the rate of the uninsured, because it does look like attitudinally it'll have some impact. So, here we go.
Thank you, Frank.
Thank you.
So Nancy and Dan, could you guys... We'll have some questions for him. Get up. We started right on, for those of you that are nuts about time like I am, we started right on time, and we're actually running 3 minutes ahead of schedule. You'll have that very rarely at these kind of things in Washington. And we'll end on time, too. So, who had a question? Yes, sir. Here, hold on one second. She's going to bring the mic. Can you hand him the mic, please? Oh, okay. We'll start. Go ahead. You have the first one. He'll have the second one. Okay. Please.
Noah Levy with the Los Angeles Times. 2 questions for you, Frank, about your breakdown of the newly insured. When you're saying on exchange, people who sign up on the exchange, you're including people who may have gone into Medicaid but come through and who are saying they got exchange coverage. Is that right?
The question wording was, did you get your insurance through a state or federal health care exchange or not? So it's individuals who said yes to that question. Okay.
So that may include some people who
could.
got directed that way.
We did not have Medicaid in the question word.
That's good. And then the other question is vis-a-vis the newly insured employed population, I guess off exchange. Would it be a reasonable presumption that that would include a large number of people who are electing their employment provided coverage that may not have elected that before, rather than a reflection of a large increase in employers that are actually offering coverage? Does that distinction make sense?
That's an excellent question. And then there's a third category, which is probably small, and those are people who are newly employed. In other words, they didn't have insurance.
Right. Oh, yeah, right.
Your assumption is a reasonable one, but I don't have data to support either of your 2 hypotheses. In other words, whether it's because employees have started to offer it or whether or not employees who said no before now have decided to take it. Those were your 2 alternatives. We did not probe that. We didn't ask that, so I don't have data that allow us to make a judgment on which of those is prevalent.
What's your question, sir?
Hi, good morning. Stephen Goldstein from Sapient. I actually have 2 questions. The first one is an English major math question. Of the roughly 3% uninsured percentage drop, what number does that make of the 7.5 million who are going through the exchange? So how many of those are, to the 3% drop, actually were uninsured to begin with and recently got insurance?
Well, that's a fair question. So Frank's data set and mine are, as Frank noted, are not entirely alignable, but we can reach some general conclusions about the two. If we know that about half of those 4% of Frank's from his data have come in through the exchanges, then I think it's reasonable to conclude that of that drop that I showed, and our estimate of a 7.25 million decline, roughly half of those are coming in now through the exchanges of newly insured, the other half coming in through other mechanisms, presumably primarily through Medicaid expansion. That would be the other big one. But to Frank's point, there's always getting a job. The labor market does continue to slowly heal, so people can pick up benefits through their employer, or just straight to insure. I mean, still getting insurance the old-fashioned way. You don't have to go through an exchange to get insurance. You can just walk into State Farm. So there is that. But, roughly half and half. And that's, I think that's an important thing to keep in mind about these numbers is about net reduction. I alluded to Senate Majority Leader Reid, who about a month ago was estimating, this was after the 4.2 million signups had come out, but before the more recent numbers. And, or no, I take that back. I think it was a more recent number, but he was coming up with 10 million newly insured. But he was basically adding some estimates on Medicaid expansion to estimates on signups for the exchanges, and simply added them together without thinking that maybe people had insurance before. In the meantime, at roughly the same time, I think just about a week earlier, John Boehner publicly noted that he thought it was a net decline in the percentage of people with insurance, because what he was doing was he was taking some number that he had, I think it was about 6 million that had been kicked off their plans, and then he took the 4.2 million signups, that was the number at the time, left out Medicaid altogether, and claimed that there'd actually been a net increase in the uninsured. So you had one estimate that was, I think, clearly too high and was doing the math wrong, and another one that was woefully too low on the other end from doing the math wrong. The point is that some people had insurance before, but the other broader point is that half of them come in through the exchanges, and that there has in fact been a net decrease in uninsured. I don't think there's any question about that.
Okay.
And I'm sorry, I did have one other question.
Oh.
And this one will put you in the hot water of interpretation. It was curious to me when I saw that the uninsured drop percentages for Republicans and for Democrats among the people who did not go through the exchanges was vastly different. So there was 30% for Republicans and 49% for Democrats. And I wouldn't have guessed that politics would have played a role in that particular not through the exchange delta. And so I was wondering what you thought brought that up.
Politics plays a role in everything relating to the Affordable Care Act. And that's the point I was trying to make, is you would think behavior would be detached from attitudes, because a lot of our business at Gallup is measuring attitudes, but attitudes matter. So I think it's not surprising to me, at any rate, that one's political orientation actually has an effect on one's behavior when it comes to insurance in the Affordable Care Act.
Frank, does it make any difference that the way we broke them out, that Republicans tend to live in the same states as Republicans now? I mean, we're more, the reds are becoming redder and the blues bluer. Did that make a difference in his answer? Because if you live in Nebraska, you get offered something very different than if you live in West Virginia. Or
There could be some of the underlying factors, and that could be a factor.
You may have an exchange difference. You may have an exchange difference by the state you live in, and the state you live in tells whether or not you're Democrat. I mean, 40 states are.
Yeah, the most Republican state in the unions are Utah and Wyoming, and they may have had different things that are offered than, say, Maryland or Rhode Island or Hawaii, which are the most democratically oriented states. So that's part of it. That's an excellent point. And also the underlying demographics. there was demographic differences in those who came to the exchange and those who didn't, and demographics are correlated with political orientation, so that's a factor as well. Younger people are more likely to come in outside the exchanges, and younger people skew more Democratic in their political orientation.
What's your question in the back there, sir?
My name is Ioannis Andreadis. I'm coming from Aristotle University of Thessaloniki, Greece. I'm very happy to be here in this building that I have been talking about to my students. I'm a political science assistant professor, and my question is political, so it goes to Frank Newport. I have observed that you have presented that whites are 4 times more likely to disapprove the policy. Have you checked for any interactions between whites and political attitudes? I mean, democratic whites are different, I suppose.
I'm not sure I fully understood, but I think you were asking about race.
And full-time. And I think and full-time employed, too.
Interaction between race and political attitudes. Democratic whites being different than Republican whites. Because you have mentioned that whites are 4 times more likely to disapprove the policy.
Yeah.
So I'm asking if you have checked.
If I understand correctly, whites were more likely to disapprove. Whites are more likely to be Republican, as we know in American society today. One of the big predictors of having a Democratic political orientation is simply giving your race or ethnicity as anything other than white. Huge differences there. And that's, statistically, the race still had an impact even above and beyond political identification. That's what I showed. But I did not have the sample size or the ability, if I hear you correctly, to break down Democratic whites versus Republican whites. That's important, and we can look at that, but we're going to have to wait until we have more sample.
Okay. Ma'am?
Yep. Good morning. I'm Nancy McCall with RTI International. I have a question for Dan and Frank. Does your poll ask questions of the uninsured, those who remain uninsured, why they remain uninsured, that might offer policy levers that the administration could consider for increasing the uptake of insurance? And that could be implemented through executive order, of course.
Did you write that down, Dan? That's an excellent, in answer to your question, no. But I think it's an excellent suggestion.
Yeah.
We might start with an open end and then follow up with a pre-coded list. There are a number of reasons that have been given. Nancy may be an expert on it. Can't afford it, don't think I'll need it, a variety of other things like that. But I think it'd be a good question to ask. For the uninsured who remain uninsured, why aren't you insured?
Or
Comment on that?
Go ahead, Nancy.
I think it's a very good question. Meaning, I don't know that we have a definitive answer on it. We would love to see more information about it.
Let's meet again in a month and we'll have the data, all right?
Okay, sir. Jim?
Jim Blassingame, Small Business Network. Dan, I have one for you, Dan, and one for you, Frank. Dan, you seem to attribute the 7.4 million or 7.3 million, 2.9, I forgot what the number is, newly insured to the advent of the ACA. Do you know how many of those people paid? Any way of knowing? There's some question about whether people enrolled and they thought they were in, but they may not have paid. Any way of differentiating those?
Right. That's an important question, and I alluded to that a little bit earlier. Is that's a bit of a wild card. When Jim was asking how low do we think this might go, I suspect we're nearing as low as we're going to see for this round. Okay, so that will start to lose momentum. We'll start to level out somewhere around where we are now. Maybe it comes down a little farther. That's my guess. One interesting question is as folks get along and discover they actually have to start paying a premium and don't want to pay the premium and fall off of their plans, how much might we see that number slowly edging back up? Nobody knows the answer to that question. Now, I do know that nationally, the state of California is looked upon as a bit of a bell cow with that, because California has been tracking it pretty closely. And so far, if memory serves, they're at about 85% of those signing up through their state exchange. California's got one of the better state exchanges out there that are, in fact, executing on their premiums. Nobody knows how that will generalize to the U.S., but a lot of people think that that's probably a pretty good estimate for how it'll end up being. So most will pay, but not everybody will pay, and some that are now saying that they have the health insurance Eventually, we'll have to concede that, no, I don't. I signed up for it at one point, but I haven't paid for it, and so I've been kicked off my premium. So that's another question that maybe we need to start asking, is have you paid for your premium?
Consequently, do you plan on continuing to run these polls in the future to track this information? And Frank, if you do, are you going to differentiate between Medicaid and the private enrolled?
That's an excellent suggestion we made. We've had actually 3 good. I hope we're taking notes.
Yeah.
Ask, have you paid? Ask uninsured why they're not uninsured, and perhaps getting more detailed on the source.
Okay.
We do know, and Nancy may speak to this, that the research is very tricky when it comes to trying to get the source, like Medicaid versus employer and so forth. I think your paper that you did showed that as well, that there can be variances by firm and other organizations in how you ask the question, how you get that, right?
Right, so I'm happy to add to that. So the work we did looking at Gallup survey, looking at other major national sources of information about health insurance coverage, people tend to underreport Medicaid coverage. You see that in other surveys as well, and people underreport in Gallup compared to administrative data as well. Yeah. So it would be great if you would ask questions about people who've got Medicaid, but we would expect that there would likely be underreporting.
Nancy, why do they underreport?
Well, that's a good question. Why do people underreport? You know, sometimes people may not have, people may have a policy with a certain name on it. They may think that they have coverage from that company rather than potentially a government program. So I think there's, you know, people may know they have health insurance coverage, and we found that Gallup tracks well compared to other government surveys, other national surveys about do people have health insurance coverage, yes or no, but doesn't track as well in terms of source of coverage, type of health insurance coverage.
Sir, what's your question right here?
Thank you. Gary Hill with Manila Consulting Group. I was struck by the national responses on the health of individual responses at 29% for very good and good. How stable is that statistic over time, and does it include both behavioral health and physical health? And is there any evidence that insurance would be related to those responses?
Yeah, that's a good question. The answer is yes to both. I don't have statistics off the top of my head that I can share with you that are profiling in nature from excellent, very good, good, fair, and poor. But when you ask self-report for other more objectively defined metrics, disease burden, have you ever been diagnosed with high blood pressure, high cholesterol, cancer, diabetes, asthma, have you ever had a heart attack, etc.? To Frank's point, BMI, self-reported height and weight. But then other things, including things like clinical diagnosis of depression, more of an emotional health metric that can also be considered a part of disease burden. And even things like how you think about and evaluate your life in general, what you call life evaluation. All of those are clearly discernible by each of those 5 categories. In other words, it worsens as you go down from one group to the next. And that's the cross-validation that Frank was talking about. So I don't know what the average rates of each would be based on those categories. I don't want to say that out loud. I could guess, but I don't want to say it out loud. But you see a real stair step. And the close downstream corollary, of course, which everybody is interested in, is actual health utilization. Or do the people who self-report excellent health utilize health care less than those that self-report poor? And the answer is yes, and by very substantial amounts. And so that's the kind of cross-validation stuff that Frank was talking about. I don't know if you had anything else that you wanted to add to that.
Okay.
We'll track it over time. Good hypothesis. If more people come into the system, the goal would be in a year or two, we should see a higher, presumably, self-reported health. If we have some other questions, we'll be tracking on the same line, but that's an empirical question. We'll see what happens.
Okay, guys, we have I'll make sure we get every question. I'm going to ask for short questions and short answers. Sir?
My name is Rick Lennox, Chestnut Health Systems. I was struck by your comments regarding the politicization of this kind of issues, and in particular, the kind of leveling off the percentages of those getting insured. And in particular, what you hear with respect to some of these political sides is that it appears that the attitudes are driving the decisions not to go into the insurance. In some ways, that's not surprising because given the attitudes are largely affective kind of issues and emotional issues, that a lot of emotional issues actually drive health behavior and not cognitive kind of behavior. So it's not about whether they're likely to get the good coverage or so forth, it's simply how they feel. And so the issues of whether or not things are going to level off, one wonders if there's going to be a chance for this political aspect to kind of dissipate over time as the current administration kind of goes away, so to speak, and perhaps is even replaced by Republicans that are less likely to cause the reactions to the Affordable Care.
Thank you.
I think that's a reasonable hypothesis because, as I said, we were anticipating we might have already seen an inflection point where the negativity would begin to narrow. You're saying as some of the emotion begins to dissipate, as the act becomes more a fait accompli going forward, as perhaps its success is better known, as the parties change here in Washington, all of that could affect the political relationship and attitudes towards the act. And if that's the case, that could affect actual rates of insurance.
How about back here? Yes.
Joanna Blonska, OMHRC. I'm wondering if you have a sense from the newly insured how many found that their premiums were affordable, and then related to that of the people who are newly insured through the exchanges, how many were eligible for tax credits?
Those again are excellent questions, but we don't have data on those. But again, that's something that in theory we could ask going forward.
How about right here?
Ken Feingold, ASPE. Will the slides be available for those of us who may be asked to summarize them but could not write quickly enough to take down all the numbers of interest?
Yes.
Thank you.
I think both of the Dan's article is already on,
yes.
Will be on Gallup.com.
That's the state level analysis. That went live this morning.
Yeah, and then later today, at least the heart of the data I presented will be available on Gallup.com. But otherwise, anything we presented, if you contacted us, we certainly could make available to you. It's in the public domain, absolutely.
That's right. And around the fourth day of every month, we come out with our new uninsured estimates for the previous full month. That editorial schedule modulates a little from month to month.
Wait a minute, Dan. I think people want to know that. When did the new estimates come out?
Well, it'll be around May 4th. Okay, I keep the word around in there because we adjust that a little bit each month based upon other stuff. But around the 4th, we'll come out with the official April numbers. We'll see how close it sticks to that 12.9 that you've seen so far.
Another thing, too, is I work here and I get overwhelmed. If you just go to the website and type in, you can get more data than you need there, too. But we'll always help you when you contact us. And we have a question back over here. Yes, Miss?
Ariel Edwards-Levy, Huffington Post. Do you have information on the approval and opinions of the ACA among the newly insured?
We don't, because the separate tracks is the bottom line, since you're a polling expert. The questions we ask about attitudes towards the ACA come from separate surveys that we come in with and go out again with modules of questions. The newly insured are based on accruing data, as you saw, over 20,000 interviews, and we can't afford on all 20,000 interviews daily to put the questions on about the ACA. So unfortunately, we don't have the sample where we can do that cross-tabulation.
I have a quick question. Dan, is this good news or bad news, do you think, for the... I'm going to call it I'm just going to say the federal government. Is that graph, is that real good news, not very good news? What is that?
Well, I think that you mean the long-term trend, the percent uninsured?
Yeah.
Yeah, I think that's good news for the proponents of the Affordable Care Act.
How good a news? Is it real, or just kind of?
I think it's pretty good news. I don't think it's great news.
On a 10-point scale, Dan.
I do think if you go back, though, gang, and so go back to that state analysis. Those states that embrace Obamacare, embrace is a euphemism, but we all know what I'm talking about, so I'll stick with it, right? Those that embrace Obamacare versus those that do not embrace. Roughly half of American adults are in Team A and roughly half are in Team B, okay? You've got the 18% from quarter 3, 2013, dropping to 15%, or last full, we'll set April in the parking lot, 15% in March, okay, a 3-point drop. Well, that 3-to-1, it's a 3-to-1 ratio for the states that have embraced it versus those that haven't in terms of the decline that they've realized. So about 3/4, so we can then make a reasonable mathematical projection that about 3/4 of that 3-point drop from 18% to 15% is coming via the states that have embraced it, and 1/4 is coming from the states that have not. So it's then not a big leap to say that if the states that have not embraced it had implemented those two major mechanisms, Medicaid expansion and a locally managed and promoted exchange, that 15% from March gets moved down to about 13.5%. That's the sand, for lack of a better way of putting it, the sand that's put in the gears from the states not implementing those two major mechanisms compared as it affects the overall decline that we have seen. So that 15% we project would maybe be closer to 13.5% for March. Big picture, I think that it's pretty good news for proponents of the Affordable Care Act.
Nancy, I don't mean to put you on the spot, and you can just say, Jim, I pass on this question. How good a news is it to you? Kind of, or?
So I'd say the goal of the Affordable Care Act is to increase health insurance coverage. That's what we're seeing, and we're very pleased that health insurance coverage rates are going up.
But what number on there would have, what percent on Dan's chart would have made you jump up and down and run around the building?
I'm not going to answer that with a specific number.
Okay, well, I wanted to get her to that point. Thank you. Any other, okay, sir? Doing great, we got 5 minutes.
Evan Salzman from the RAND Corporation. I guess your survey doesn't track children, but do you have any plans to track uninsured among the rate of uninsurance among children in the future, to ask, when you do your surveys of adults whether their children have coverage?
That's a good question, and Dan can speak to it. That's tricky. As you know, if you're in the business, it's under 18, it's difficult to do ongoing surveys. A lot of times, particularly under 16, you need parental permission, and it's very complex to survey. We could do what you suggested, which we have done in other instances when we're doing education surveys and elsewhere, and use the respondents who are parents as surrogates for their children to report what their children are doing or not, and that would be possible. But at the moment, we don't include that because it's a complex and time-consuming process. But Dan, I don't know. That would be.
Yeah, I don't have much to add. We don't go under 18. We could go, we've talked about going as low as 15, which is what the World Poll does internationally. But we don't, and you bump into tricky stuff when it comes to survey research when you get into the younger age group. So we generally have steered clear of it. It'd be great data to have, but those are data that we don't.
Frank, what percent of Americans are following this at all? I always see that stuff on TV where they interview people, but how many people know what the Affordable Care Act is or Obamacare?
Well, I did show one chart where we have it over 7 out of 10 who claim they are familiar with it, and that's
7 out of 10.
Up. Yeah, and that's how familiar we didn't do a quiz. So, and I would probably flunk a quiz because, as Nancy can attest, it's very. As it's true for any legislation in today's world, right? It's a 1,000 or how many pages is it? But it's extremely complex legislation. But 7 out of 10 claim they're familiar with it, which leaves less than 30% that claim they're not. And that's higher than obviously are familiar with a lot of other things that are going on, like international trade treaties and so forth. Would be much lower.
I don't know how many other Americans feel the same, but I feel like the biggest problems, I know how bad it is to not be uninsured. I'm not either oring them, but we're really, again, as a businessman, it looks to me like we're just moving the deck chairs around. What we're really doing is just saying, how are we going to move the money around? Who's going to pay? So somehow we're going to figure this out, but who's going to pay? Where the biggest problem is actually we can't afford the cost. The cost is clearly breaking. It's clearly, I don't think it can be any other side to it, is breaking us. As people kind of lift the veil off of that 800-pound gorilla, do you think that'll shift the attitudes of this? Maybe this will be our last, just make remarks to this and we'll wrap up.
It's a good question. I do know the Affordable Care Act.
piece into the Affordable Care Act.
But it certainly has built into it in the complex piece of legislation attempts to bring down costs. I mean, that was part of the act itself, and I think the legislation was cognizant of the fact that the costs were a huge issue. So trying to bring it down by, for example, paying for free preventative is supposedly going to bring down cost in the long run in a variety, and moving towards managed team care as opposed to individual pay for service, a variety of things that were thought through in the Affordable Care Act, as I understand it, to try to bring down costs. But a good question. I don't know to what degree the average American is aware of how big a percent of the budget of
But Frank, on the list that you ask of what people are concerned about, it's jobs and economy. We know that they're not cared about environment. We know they don't really care about Syria and Crimea and all that kind of stuff. Where's this right now? The
healthcare
cost of health
is up a little, but you're absolutely right. We ask every single month, we say, what's the most important problem facing the country? And, at least half net out something economic, either the economy in general or jobs, and those are by far the dominant problem. Healthcare can come up and down as it's in the news. For example, back in 93, 94, all of a sudden people said healthcare was our big problem because the Clinton administration was embracing the attempt to reform healthcare. Then it dropped way down. It's been up more recently because it's in the news, but it's still in third or fourth place, significantly below anything economic. So if we're giving advice to anybody who's an elected representative, the public would like you to focus first on the economy and jobs.
You guys, it's exactly 11 o'clock. Thank you, Nancy. Thank you, Frank. Thank you, Dan. And thank you all for coming. We're adjourned.